Okay, treatment, type 2 diabetes. First of all, first line of treatment in type 2 diabetes is always diet, right? Or lifestyle changes, actually. So you get exercise and diet. Avoid all the straight sweets, stuff like that. Things that really stress the system, the system to control. Yeah, so avoid those straight sweets. Lose weight. Exercise, right? Exercising actually decreases or increases the um, sensitivity of the insulin receptor. So in other words, it decreases the resistance to insulin. Uh, and it also exercise also can lead to weight loss, um, decrease obesity. So that's always got to be your first line. Second line, first drug in as far as drugs go, is your guanides. Guanide. Okay, this guy here, metformin. That's what we're talking about when we're talking about guanides. Metformin, which is glucophage. Right? Decreases the amount of glycogen being converted back to glucose. So in other words, it's decreasing the amount of glucose being released back into the bloodstream. And it also increases insulin receptor sensitivity. It increases resistance. So that's a great thing there, because that's the problem with type 2 diabetes is that you have a decrease in your receptor sensitivity. So insulin resistance is the problem with type 2 diabetes. So you're taking care of that problem. Now this is attacking right on that problem. It also slightly reduces glucose absorption in the gut. So I got to put slightly. Reduces glucose. If I reduces glucose, I'm just going to put GI absorption. So, now a good thing to note is that it does not stimulate the release of insulin, right? It does not do that. And the reason I say that is because now I'm going to talk about side effects. You can have a decrease in appetite. Not necessarily a bad thing, right? Unfortunately, though, you do have nausea. I'm just going to write about nausea and diarrhea. Weight loss, right? Makes sense. Decrease in appetite, weight loss. Right? And then a toxic effect. toxic effect is lactic acidosis. And what metformin can do at this high level is it can block the oxygen usage in the mitochondria. The mitochondria are the powerhouses of the cell where this stuff takes place. So it blocks this. So when oxygen isn't able to be used, and we can do anaerobic metabolism with lactate, but you end up with lactic acidosis when you have that happen. So that's how you can end up with lactic acidosis when the use of metformin. First drug we go to. They'll even use metformin a lot of times in pre-diabetes. Statistics have shown that when you use metformin on pre-diabetic, that they're a lot less likely to end up being diabetic, and it makes sense because you're kind of helping the things that are problems, and you are also you can also very often help with the obesity if that's been part of the problem, and decreasing their appetite, and so it makes a lot of the lifestyle changes actually easier when they're taking the metformin. So it does make sense that it can stop the progression from pre-diabetes to actual diabetes. The next one I want to talk about here is sulfonylureas, and I don't want to use that blue one. The damn thing doesn't wipe off the board very easy. So I'll use brown. Sulfonylureas. And these guys here, this here is glipizide. Which is also called glucotrol. Now, I want you to know that as far as the sulfonylureas go, the book I was looking at had the first generation and second generation in them. And then when I looked at your book, I realized that you guys don't have the first generation in them. And it makes sense because second generation, the only ones out there that you see used anymore. I kind of crossed it out here. Tolbutamide is a first generation. And the reason is because the second generation are effective at a lot lower dose. And they also they have a lot fewer side effects. So nobody uses the first generation anymore, just the second generation. And the Lewis 10 here, the 10th edition, the one that you guys are using, doesn't even mention first generation anymore. And I think that's probably a good thing. Why tell you a bunch of crap you don't need? Like I never do that. Glyburide, I try not to, believe it or not. Sometimes it's hard to decide what you're going to need and what you aren't. Glyburide. Definitely can't tell you everything. And that there is called diabeta. And glimepiride. And that one is Amaryl. I'm sure you've heard of that. And what do these guys do? Sulfonylureas. They increase insulin release. That's what they do. And you might say, well, why are we wanting to increase insulin release with a type 2 diabetic? Well, because they already have the insulin, right? Why are we trying to increase insulin release? Well, the thing is remember that the cells do respond to insulin. It's just that it takes a lot of it. So maybe if you can give them this and you can get a little bit more insulin out there, it might actually help. It might actually help lower the blood sugar. So by doing that, we might actually be able to help lower the blood sugar. Another thing, when they get kind of towards the end there and they're not putting out enough insulin because they're all wearing out, they might want to kind of give them a little boost. I always kind of wondered if that speeds up the death of the cells. I don't know, but anyway, that's what sulfonylureas do, is they increase insulin release. So when we talk about side effects, first thing that I want to mention here is hypoglycemia. Their blood sugar can get too low. That's because you're giving them something that artificially increases insulin release, right? It's supposed to be released when your blood sugar goes up. Well, you're giving them something that it will increase that over and above what your system is automatically wanting it to do. So So if the person doesn't eat, they take this and they don't eat like they normally do, or they're more active than they normally are, and they're doing something here that they're going to use up more of this, more of their glucose, they can actually end up hypoglycemic. Doesn't happen a lot, and most of the time it's not a real bad. It's kind of a lightheaded, they don't feel so good, and they eat something and they're okay. But it can run into a whole full-blown hypoglycemic reaction. Occasionally it will run into that. And we aren't talking much about hypoglycemic reactions in these videos. Hypoglycemia is a reaction here. You notice I did not mention this when we were talking about metformin. Metformin does not increase insulin release. That's why I made a point to say metformin does not increase insulin release, because then that leaves this side effect is not a problem, right? So this isn't something that we have to deal with a whole lot of. Another thing that this here will do is it will cause weight gain. Now remember, the other one was weight loss, but now weight gain. They can get nausea and vomiting with alcohol use. So I'm just going to go like this here. There's a warning window here I'm putting in, right? Nausea and vomiting with alcohol use. Now, this is kind of like an antabuse effect. If you know what antabuse is a medicine that you give alcoholics. They don't want to drink, but every evening they get this urge and they can't let it go. Well, in the morning when they're thinking straight, you give them a pill. So here, take this antabuse pill, right? This, or maybe this is somebody who's allowed out as long as they don't drink, and you have to show up every morning. We give you an antabuse pill. So that, and if you take an antabuse pill and then you drink, you're going to wish like hell that you didn't drink, because you'll get really bad nausea and vomiting. Happens quite a bit though. The drinker will go ahead and give it a try once, then they won't do it again, and they end up coming in the emergency room. It's so bad. They come in the emergency room and start an IV. We give them an antiemetic. We give them some fluids, and they wish like hell they never drank. You know, that they didn't do this. Sulfonylureas give an antabuse-like reaction. So if they're on this, they have to know, don't drink, right? I don't think it's as bad as the antabuse reaction, but it's an antabuse-like reaction. Thiazolidinediones. Thiazolidinediones is what your book calls them. I like to call them glitazones because they all end in glitazone, and that's what most people call them, because glitazone is a lot easier to say than thiazolidinediones. I'm going to put down my glitazones. And thiazolidinediones. How's that for a word? Holy crap. TZDs. I'm going to go ahead and tell you this whole story about these glitazones. Is a drug that was the first one that was ever released, is this troglitazone. Glitizone. It's not in use anymore. Troglitazone was released and was not out very long, and it was taken off the market. And it was pulled off because it had severe hepatic damage, or say liver damage. So that's a pretty good reason to pull it off the market, don't you think? Well, then the next ones here that were released, rosiglitazone. So I'm going to go ahead and put that on So rosiglitazone was released shortly after, and it was looked over real well. I mean, of course, you know, after this bad thing happened, FDA says, yeah, it's okay, and boom, they had to pull it. Better believe they were looking at this rosiglitazone really well. And as they started doing studies on it, they found that they had problems with it too. All glitazones, they found some hepatic deficit in when they're on them. But as far as the rosiglitazone, which is also called, by the way, it's also called Avandia, and that's probably that's the only one that I knew. Avandia. And with this one, the problems that they found with it was they had a lot of people that were on it tended to have myocardial infarctions, and they should know because they didn't have the normal progression of MI, and they had sudden cardiac death. Right, so that's two pretty severe reactions, and so now very limited use of this drug. Right, don't see it out there. It's only used very limited for certain. Only certain prescribers can actually use it. It's this special level. And now the one that leaves us with one more that's out there, and you see it quite a bit. Bio or PO glitazone. They're the glitazones, and this one here is called Actos. And that one's still out there. That's the one that's out there being used now. Out of the glitazones, it's the only one really left that you're going to see. Side effects, of course, hepatotoxicity. Hepatotoxicity. Let's see. Heart problems. Renal retention. Renal is your kidney, right? Renal retention. And if you think about it, you got heart problems, heart failure, and renal retention. Now we're going to get edema. Makes sense, right? Kidneys aren't getting rid of fluid. You got heart failure. That's a bad combination. Of course, you do not ever use it with a patient with heart failure. Patient has heart failure, don't use it. Okay, so that's the glitazones, or the thiazolidinediones. One more to talk about, and it's a pretty cool one. Okay. One more. Thank God. I can go to bed. Okay. Alpha glucosidase inhibitors. And they'll call these guys starch blockers. Starch blockers. You got to think, everything, the things that we eat, right? Carbs that we eat are fairly complex carbs. Polysaccharides, they have lots of. You got to get them broke down to a glucose molecule, which is a monosaccharide, and you've got polysaccharides, which means many. It's like this big conglomerate that has to be broke all down. So you start out with your starch, your carbs. Let's just put carbs, which is your starch, whatever you want to call it, right? And these are polysaccharides. So let's just draw them in a straight line because it'll be easy. 1, 2, 3, 4. No, try to keep it even. We eat this carb, piece of cake or bread or something, right? We got this starch that we just ingested. In our mouth, you have salivary amylase. We got gastric acid in our stomach. And then we have pancreatic amylase in our duodenum. So mouth, stomach, duodenum. We got a couple amylases and some gastric acid. That's all breaking this stuff up. Taking these guys and it's busting them up, right? Trying to get them broke down. It's got to get them broke down to monosaccharides. But what these guys do, they do a lot of the work, most of the work, but not all of the work. So they get them broke down into disaccharides. And there's actually some other steps here, but we kind of show you how it happens. 4, 5, 6. So this guy here was in that big long line. Now we got him in 3 disaccharides, right? And what happens here? We have a brush border enzyme is going to act on these guys. Brush border enzyme is alpha glucosidase. And now brush border enzymes are enzymes. They are products of the normal flora in our GI tract. So we'll talk about them a lot. We'll talk about them. This isn't going to be the only time you hear I'll be talking about them. But in this case, we're talking about the one that we're talking about is this alpha glucosidase. GLUCOSIDASE, right? And what these guys do, they act on the disaccharides and turn them into monosaccharides. Now they can be absorbed, right? So they get to this point, they can be absorbed. So now you've got this. Right? You got mono. Instead of here, you got that big line. It's broken into 3 disaccharides. Now you got these 6 individual monosaccharides. Of course, those numbers mean nothing other than the fact that's how many I happen to want to draw on there. But now you've got glucose molecules. They can be absorbed they can be absorbed in the gut. They can be taken through the portal circulation over to the liver, and the liver can do whatever it's got to do. It can store it with insulin, or it can do whatever. But anyway, this is what has to happen in order for that to happen. Now, it does not take a genius. You see that alpha glucosidase breaks the disaccharides into monosaccharides. It does not take a genius to figure out what an alpha glucosidase inhibitor does. Can you figure that out? Right? It does. It stops alpha glucosidase action on the disaccharides. So it never gets to be the monosaccharides. So what it does is it cuts down on the amount of glucose that we absorb. Works really well with people who can't control their ingestion. You don't stop eating it, we'll just make it so it doesn't get absorbed, right? There is an unfortunate side effect on this. Well, you've got a lot of disaccharides getting into the colon. They don't normally get there. They're usually broke down and absorbed, right? These guys are going down into the colon. In the colon, you got a whole lot of bacteria there. This bacteria they have a feast on this stuff, right? It's like, wow, we got a whole lot of crap in here that we're usually just bottom feeders. Don't get nothing. But we're getting a lot of really good stuff here to eat. So they just feast and they really go crazy on this stuff. So what do you think happens? A product of bacterial ingestion, digestion, metabolism is gas, stinky gas. So a side effect of this stuff here is you fart. And you get gas. Gas, which can cause a lot of lower abdominal discomfort. So, if you think about it, it makes sense. Whenever you think about bacteria, right? If you get something that dies out in your backyard, it stinks, right? A corpse stinks because the bacteria feast on that, and you get this gas. If you've ever seen a corpse, they get kind of blown up, right? They kind of get all puffed up, and that's all the gas. You get under the skin, you got all this bacteria feasting on what's left of this whatever it is that died, and it ends up all puffed up. And that's because of all the gas from this bacterial ingestion. Well, that's what's happening down here. It's happening down in your colon and your fart, right? That's kind of the same thing. When you eat beans, it tends to get all the way through. The molecular makeup tends to get more down into the colon and feed these bacteria better. So anyway, This is your side effect of alpha glucosidase inhibitors. That's how they stop you from happening. I think that was the last one. Yes, that was the last one. It means I'll get to go to bed here.